Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. In today's episode, we discuss practical strategies to overcome barriers to hepatitis B care. I'm joined by three faculty: Dr. Patricia Jones, Associate Professor of Clinical Medicine at University of Miami Miller School of Medicine; Dr. Mindie Nguyen, Professor of Medicine of GI, Hepatology, and Liver Transplant at Stanford in California; and Jennifer Wild, Patient Advocate for HBV, as well as a clinical nurse at UCSF Cancer Center in California. This episode is part of a larger educational program titled Path to Elimination: Simplifying Screening and Treatment for Viral Hepatitis in Priority Populations. For more information on our faculty, along with the link to the larger educational program, please visit the link in the show notes for this episode. Now let's get started with Dr. Mindie Nguyen.
So let's talk about how to overcome the health insurance navigation barriers a little bit. So number one is generic medications when possible. One, tenofovir and entecavir, both of those have been generic. There's one more tenofovir form that is expected to become generic next year. That medication would lose patent in 2026. And health or care navigator. So now this, it really depends on the system. Maybe some system has a specific care navigator, some don't. So my care navigator is my nurse. So she is really resourceful. She would have sites that the patient can go and get coupons and this and that. So you need to identify the local resources. And if you need help in your area, one source that I would encourage you to check is with the hepatitisbfoundation.org. And there are some other programs here: Prepare Toolkit, State Resources from Liver Foundation, and also other Hep B Free in New York City.org here. They have a lot of resources that you may find useful. And, other thing is insurance enrollment outreach via community venues. So all of these are pretty specific local resources. So cost insurance issues, that's part of the healthcare access. Now, healthcare access also includes ability to get into a clinic, to make an appointment. There are barriers to that due to many other issues. There are religious and cultural values that may make an individual to feel less comfortable to come forward, be tested. Stigma is closely tied to it. The HBV myths, it can come from that there's no treatment. In a recent study that I saw a survey, then a good amount of patients feel that it doesn't matter because there's no good treatment for HBV, which is not true. And that's sort of linked to the next box here, which is knowledge. So perception toward prevention. So at this point, I will turn over to Jennifer to go through some of these points in more details.
Thank you. This is, I think, one of the main discussions we want to focus on today. There are many different kinds of barriers, and one of the barriers that comes up often are myths and stigma in patients and their communities. And so, open-ended question is, what types of myths and stigma have you encountered from your patients in your practice? And what are some strategies to address some of those things? I think in my patient population, people are often not symptomatic until they've got further stage disease, further stage cirrhosis or cancer. And so I think one of the misconceptions I struggle to address with my patients is that they are deserving of treatment, of evaluation and treatment, even before symptoms set in, that it's not something that can be fixed with lifestyle changes necessarily. What about you, Dr. Jones?
I'd say stigma is a big issue. And one of the things that is interesting to me, I've had patients who, their family even will tell them, well, you got that infection because you are sexually active. These are in adolescents who aren't even sexually active. I have a family that I care for, and I've heard from patients that even healthcare professionals can treat them pretty poorly. And this person is a nurse and says that she overhears other colleagues talking badly about patients or being concerned that they might get the infection. So there's a lot of stigma even in the healthcare setting that I think impacts these patients. And the other thing that we haven't mentioned is that the treatment for Hep B is also one of the treatments for HIV. And so there's a lot of conflation with the diagnosis. And I think that sometimes patients are really reluctant. I've had people tell me, but that medicine's used for HIV. And people will think I have HIV. And, I don't tell people I'm on this medication, which is a real problem for drug interactions. So I think those are the issues I've had with stigma. And in terms of how I address them, I just do my best to counsel. It's not something that in general you can fix in one session. It's going to take patience and just trying to understand that person's perspective and their lived experience and trying to encourage them.
Yeah. And Dr. Nguyen, what kinds of barriers that you think your patients frequently bring up?
I think for stigma, it really depends on where they come from. Some of our patients come from places where HPV diagnosis would disqualify them from jobs and getting into some schools. So I think here is where more education may be useful, and also to help the patient navigate to providers that they feel comfortable with, that they can trust.
Yeah, that's really interesting that you brought up school. I'm a patient advocate, but I'm also a patient. And so I always joke that changing my major in undergrad is what saved my life, because I would not have had such further in-depth screening to further elucidate my Hep B status if I hadn't decided to go to nursing school. And so even though both of my adoptive parents work in healthcare, and I had my vaccines and they were all documented on my vaccine record, I had never actually been tested for surface antigen my entire life until I was 22 years old. And so even people who do have access to care, I think, still can be missed in testing. I should have been screened under the new guidelines for having been born abroad and being an Asian person and having elevated ALT after a while. But even then, I think, even among my adoptive parents who are not Asian or Black, they're white, there was still some shame. They felt like they had somehow let this happen. And so I think there are a lot of different beliefs around this is a bad thing. It's like incurable. And so it's like a life sentence of some kind. I think it's really hard sometimes for people to talk about it, even people who have a high level of education. And so what are some strategies then? I mean, we've talked briefly about some of these different beliefs and myths, but what are some practical strategies that we can try to implement to address stigma? I think that informing patients and populations about how it's not necessarily and perhaps not at all their fault, that it's just something that happens and there's not anything that a person could have or should have done different necessarily to have avoided it. Sometimes just, I think bringing that up is like the first way to talk about stigma. But as Dr. Jones mentioned, I do agree that it is something that has to be discussed serially. And I think this is one of those things too, where talking about it over and over again to build that trust is really helpful. But what do you both think? Dr. Nguyen first?
So we say about navigating to a provider where the patient would feel comfortable, but at a practical level, how do patients do that, right? Even though I live in the Bay Area, many times when patient sees me, they would say that, doctor, I've been waiting for 4 or 5 months for this appointment. And many of my patients tell me that they have the hardest time getting a primary care doctor, so it's so difficult to get in to see any primary care doctor at all or any liver doctors at all. So what do patients do? So I feel that besides getting to the right provider, to get the test, etc., we would need, I think, to outreach to patient education directly.
Yeah, I'd agree. And I say one of the things now that I'm learning more as people are sharing more about their lived experience, both patient and provider education on the stigma aspect of diagnosing and treating hepatitis B, I think is something that we need to definitely move towards, because I think that's what is going to make the most difference. And then word of mouth, the more people that are taking it and are willing to share, because that's another thing that people are, because of the stigma, not really willing to share that they have hepatitis B. But the more people that have it and share that I have it, I take the medicine and I'm doing pretty well with it, I think that might lead to some change over time and the perception and willingness.
Yeah, definitely. I can say that that has helped me with at least a handful of patients over the years, that for me personally, to be really honest with them and say, look, before you start your cancer treatment, you've been prescribed tenofovir, and I just want to go through your medication compliance, and it looks like you reported you're not taking this one. And sometimes telling them, like, I'm actually on that drug really makes them think about it again. Like, okay, well, then you can tell me honestly, like, what the side effects are and if you've been able to be good with it. And it does help. You're right, sharing firsthand experience.
Yeah, I'll share some solutions to overcome stigma. So we talked about this a bit, but to reinforce communicating with patients and community members to understand their beliefs and fears regarding HPV. So not making assumptions about what they might be, but actually communicating, creating and promoting linguistically and culturally appropriate educational activities for patients and communities about how one acquires Hep B, what it's like to live with Hep B, and what kind of monitoring and treatment. And then certainly advocating for regulations that support people with chronic Hep B and facilitating patient involvement. I think this cannot be stated more strongly, but social support networking groups so that there can be a sense of community. So one example is hepbcommunity.org. So now we'll talk a little bit about language barriers. And I think this is really important that there are language barriers in the groups that are most often affected by hepatitis B, African immigrants and Asian Americans. And so there are over 2,100 languages or dialects spoken from African languages, and about 2,300 Asian languages or dialects spoken. Many African languages are oral and there's little available in the written form. And then many Asian languages may use symbols or ideographs. And so there may not be a linguistically similar or familiar term for hepatitis B in the patient's language. And very importantly, not all languages are supported by interpretation or translation services. So some of the solutions to overcome language barriers include bilingual or multilingual healthcare providers, medical interpreters in person or video is preferred over telephonic, but certainly most healthcare systems have the ability to secure an interpreter for the patient. And then use of family members as interpreter is appropriate if it's requested, but making sure that the language culturally appropriate and language specific educational materials, and then using secure language specific mobile apps to facilitate communications between patients and care navigators or patients and their healthcare providers. So we'll talk a little bit about community-based interventions that can address other patient and system level barriers, including those barriers that are limited access to care involving PCPs and supporting community-based non-traditional testing types, such as health fairs, grocery stores, segregated service delivery. So leveraging existing care models that have worked, focusing just on the one thing. There's so many things that need to be addressed in a primary care setting. So maybe thinking about hepatitis B in the way that some have thought about hepatitis C or COVID-19, engaging stakeholders to work together. So patients, healthcare providers, health systems, payers, advocacy groups, industry, and health departments. And then in terms of a barrier of conflicting guideline recommendations, aligning guidelines. So align with the CDC universal screening recommendation and the WHO simplified treatment recommendation. And there is a need for community-based interventions because, as we mentioned, it's difficult to get into a PCP. Some people don't have the insurance. So targeted outreach to specific communities, education campaigns, accessible screening opportunities, vaccination programs, peer education using trained community members, and then again, patient navigation. There are some examples of really successful community-based HBV interventions. So, for example, in African communities, there's been the Hepatitis Outreach Network screening program in New York, which provided HBV screenings at different places, community centers, places of worship, utilized the patient navigator and offered incentive. Similar program is the Check Hep B navigation program in the Bronx. And in Asian communities, there have been similar interventions. So the Hep B Free campaign in San Francisco, which provided testing, vaccination, and follow-up, as well as education to healthcare providers, mass media and grassroots messaging, community events and fairs, and the Be Free NYC pilot program, which leveraged key stakeholders from the community, utilized media and outreach, and then offered free screening and vaccination or free and low-cost treatment.
So those are some really tremendous examples of community-based interventions and strategies. But what other strategies have either of you utilized? I think one thing that maybe isn't community-based, but I think is still like part of our community-focused care is that I like to get the social worker involved to help my patients apply for state insurance if they're underinsured, for example, because I think that helping with the cost of treatment, helping with the cost of repeated lab checks, every few months, those kinds of things can be barriers to remaining in care. And so getting social work involved, I think, can be helpful with some of these communities too. But what other broader community-based strategies do both of you implement?
I think similar things that we've done is sort of leveraging some health fairs. We've tested one of the things that's on the slide is sort of point of care testing. We've done some studies really trying to understand acceptability of community-based testing, and it's widely acceptable. But that's what I've done is sort of leverage health fairs that are being run by our community service organizations to provide education and testing.
And so maybe both of you can teach me a little bit about this. The point of care testing, are we talking like finger prick like you would do for glucose, or what kind of point of care testing is available for Hep B nowadays?
There aren't, and that's the challenge. That's why it hasn't been scaled up as widely. I'd say in the United States, there aren't. And so it hasn't been scaled up as widely because there's not a test that allows you to diagnose right on the spot. And so really the gold standard is still blood draw, phlebotomy, which takes time. We were testing a method using dried blood spots, which had its challenges, but that is one of the limitations, I think.
I mean, these tests do exist, but they're just not available in the US that we can order. Not exactly sure why, but it probably has to do with, like getting certification for it. Like, for example, I can just imagine if at my clinic, if we buy a bunch of this, who's going to do it and how to get certified for it. So it comes up with, just more logistic. So that may be why it's not available, here for us to do.
That's why I think advocacy comes in, because these do exist and they have great performance. So that's our next step, I think.
That's a great point. I think too that when Dr. Nguyen, you said that it's just not available in the US, I think part of the approach needs to be increasing access to care, strengthening what the US healthcare system can do for patients, what's covered, what is part of the structure of our healthcare system. I think when patients have more access to their primary cares, that's really, I think, the first, probably most potentially impactful change would be improving access to primary care.
Once I have a primary care doctor, getting a surface antigen Hep B test is the same as getting cholesterol.
Right. I remember reading some data from the Kaiser Family Foundation, and I believe it was that approximately 50% of undocumented immigrants do not have health insurance. And even of those immigrants who have immigrated lawfully, like myself, only about 20% have health insurance coverage. And I think this data was from the last 2 years or so. And so when you think about what we were talking about earlier on about how chronic Hep B impacts people who are born abroad, and if that data is telling us a story that we can apply here to this patient population, that 1 in 5 don't even have health insurance, then of course, how are they going to enter care? And so, I think increasing access to primary care is a big part of it.
I think our immigrant communities tend to cluster, in certain areas. So, when I work with certain nonprofits like Asian Health Foundations, when we design these programs for hepatitis B patients, we tend to do like in San Francisco, in New York, in Houston, area where these community kind of concentrate on. So that one. And the other thing is also to find speakers and faculty who are part of that community. You can bring in one faculty from somewhere else, but at least 1 or 2 should be there. So people that the community identify with.
Thank you, Drs. Jones and Nguyen and Jennifer Wild, and many thanks to you, our listeners, for joining in. As a reminder, to view the full program, Path to Elimination, Simplifying Screening and Treatment of Viral Hepatitis in Priority Populations, please click on the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.